My name is Crystal Norman. I have been working in the long-term care field for over a decade. I really don't even know where it really started, but I worked at an assisted living as a CNA. I worked at a private home care agency, and then I worked at Senior Services of Forsyth County. And now I work for the Piedmont Triad Regional Council Area Agency on Aging. That's a mouthful. To best understand the agency I work for, we are a 12-county region, and we work with over 50 providers over those 12 counties, and they provide aging services. They may be a nonprofit, they may be part of a county or city agency, but we're the pass-through, the fiduciary for federal and state funds. We help them with planning and advocacy. But that's a very far reach, right? But I can explain more if you have questions, but today I'm really going to focus on Medicare and Medicaid. Let's see, let me get to the beginning. Share my screen. Oh. Here we go. Everybody see it okay?
Mm-hmm. Yes.
All right. So at the top here, you see Senior Services. And I just want to say that's because I still want to give the rights to Senior Services, because that is where this presentation was originally built in combination with the helpline and with Kristen Perry last year. So I want to be able to still acknowledge them as part of this information. All about the basics, Medicare versus Medicaid. So today's topic really is what they say a high level overview. They're huge topics. There's so many intricate parts to it that I couldn't possibly cover it in an hour. So what I'm going to do is go through my presentation and hopefully have enough time for you guys to answer, ask all your pertinent questions. So this is a visual representation of what people feel like when they start talking about Medicare or Medicaid, just not knowing which way to go. And I guess my first question to you guys, get you interacted, is can anyone tell me the difference between Medicare and Medicaid? Just raise your hand if you feel like you have a good understanding of the difference between the two. 3 participants raise your hand. Okay, well, good. I'm glad that you guys feel that way. Hopefully by the end, we'll have more that can raise their hand here. So Medicare is an entitlement. It's a federal program that provides health coverage if you are 65 and older or have a severe disability, no matter your income. So you are entitled to this program because you have paid into it over your life, or most people have. If you've worked 40 quarters, you paid into this, you are eligible and receive Medicare benefits. And Medicaid is an eligibility program. It is a state and federal program that provides health coverage if you have very low income. If you're eligible for both Medicare and Medicaid, we call these folks dual eligible. You can have both, and they work together to provide you health coverage at a very low cost. I got this information from Medicare Interactive, and I should be able to, at each slide, be able to explain where I get the information. So next, I want to talk about the Medicare card. We always call it the red, white, and blue card. It has changed the look in a couple of years, and that's because if you see here under the name, this says Medicare number. This used to be your Social Security number, but because it's such a high population that is subject to fraud, they took the Social Security number off and replaced it with what they call an MBI, Medicare Beneficiary ID. So this happened probably about 3 or 4 years ago. So I'll land here to say, if you have someone that has Medicare in your family, has had it for a while, be sure that they have this card. This last year, I worked with a few older adults who still were not using the correct card they were still carrying around the old one with their Social Security. And they've been advised to shred it. Some people don't feel comfortable shredding it. So at least tell them that they need to tuck that one away and use this one. You can always call Social Security and get a new one sent to you. Here it also spells out when you're Part A and Part B, when you became eligible. This is really important for those people when they're applying, when they're looking for plans. It helps identify, there might be a bunch of John Smiths, and the combination of the ID number and the dates you apply for benefits are ways in which the government can figure out who you are. So it's always important to keep this card handy. So Medicare, again, it's a federal funded program. So those who are over 65 or with a disability as defined by the Social Security Administration, which I have the definition from the Social Security website here. But the best way I can explain it is it's someone who's already receiving Social Security disability benefits. Okay, so if you've applied for Social Security, but you haven't been approved yet, right, then you're not going to be eligible for Medicare. Most people, the way it rolls is Medicare automatically enrolls you in the 25th month. So you have to receive Social Security disabilities for 2 whole years, 24 months before Medicare will kick in. But this is important to know that there are lots of beneficiaries out there who are not 65 and older. Okay, so a lot of people associate Medicare with only older adults, but there are folks who are disabled who also receive these benefits. When you want to receive your Medicare benefits, you actually call Social Security. Social Security website, the ssa.gov website, the phone number, or visit your local office are 3 ways you can apply for your benefits. Social Security offices have been closed for quite a while. They opened I think we got an email maybe 2 weeks ago that they were opening back up. But if you have a loved one you care for, or you're interested in benefits yourself, no matter your age, I would suggest setting up a profile and setting up a login for the Social Security website, the myssa.gov. Back in the day, some of you have probably been walking long enough that you used to get that pamphlet that said how much you earned each year. It was like a little 2-page pamphlet. That's never mailed anymore, but all that information is on the Social Security website. It can tell you if you become disabled at a certain age, what you'll earn. It can tell you if you retire at 62 versus your full retirement age, 66 and a half, what will be the difference of those incomes. But in addition to that, you can also apply for your Medicare benefits through that portal. That saves you time in being on the phone with Social Security or having to try to set up an appointment with the office. So this website is very useful. If the older adult can't utilize it themselves, there are some sheets that kind of give you a tutorial. But it also may be helpful if they had a family or friend that could help walk them through those steps. Original Medicare. So that red, white, and blue card represent what we call original Medicare. That's A and B. Those are what I would call almost your core part of your Medicare benefits. A is for your hospital insurance, and it costs $0 for those that are eligible, meaning those that have worked 40 quarters, as I said before. Okay, so that's the equivalent of 10 years. You've paid in enough to make your premium for that part of Medicare free to you. Medical insurance, Part B, which you think of the things that are covered under hospital versus medical. Hospital kind of makes sense of what it would do, right? If you were inpatient, sometimes there are some benefits like home health afterwards, but medical insurance, Part B, is really your standard ambulatory care, your doctor's visits, your outpatient procedures, your labs. But those two combined are your Medicare insurance, original Medicare. And really knowing the difference between what A and B cover, a lot of people don't really understand it. It's not necessary to maybe define them differently, because at the end you use them in conjunction with each other, right? The only time someone needs to know about their A versus B, if you continue to work, say past your retirement age, and you don't want to enroll in Part B, you can elect an A only. So, you know, there's a few people who may have A without B, but very few people would have that situation. So Part B costs $170 a month, and people don't realize this until they actually enroll in Medicare, but you still have to pay a premium for your Medicare insurance. Most people don't realize they're paying for it because once they elect their Social Security benefits, that Part B gets deducted before they even see it hit the bank. But if you had someone who didn't know what they were paying and didn't realize it, the Social Security statement you get at the end of the year, every year, it shows you what your gross income is from Social Security, and then it'll tell you what it is once that deductible, that premium comes out. So, and this is important for two reasons. One is people, one thing is that people need to understand that no matter what type of Medicare benefits they get, they will have to pay this premium unless their income is below a certain threshold. We can talk about that later, but that's going to be the premium this year. The second reason this is important is because when you apply for certain benefits, they ask you what your income is, and they're always looking for your gross income. So they want to know what you're making prior to your Part B premium coming out. So just something to think about, like if you had someone applying for Medicaid benefits, they're really looking to see what your income is before your Part B premium comes out. Next is your Medigap or supplement. These are to help cover the costs A and B don't. So A and B together cover about 80% of your insurance, your medical costs, and you're left with 20% of that. And there's no cap on that. You know, you will pay 20% of all your medical costs indefinitely, right? There's no yearly cap. So most people can't or do not want to pay that 20% out of pocket. So they buy these supplement plans, and all they do is just pay the difference of what A and B doesn't. They don't pay for things not covered by Medicare. They only pay the difference of what Medicare can't pay. And there are different supplement plans, but they cost quite a bit. You're say 65 and a female, it might cost you $100 a month to purchase one. But that cost will go up with the cost of living and your age over years. But some people like this because you basically, once you pay for it, you get your A and B and you get your supplement, you have no out-of-pocket costs. So you may pay, a couple hundred in a premium, but on the back end, you really don't have any out-of-pocket costs. So some people like this. On the other side of that, you can get a Medicare Advantage plan. And this works a lot like an employer plan. It's a managed care organization that offers either an HMO or a PPO style plan. They contract with Medicare and they say, we'll cover A and B, what that covers. And then we will contract with the network, a hospital system, whatever, and we will reduce those, out-of-pocket costs. And it will show up to the beneficiary as a copay or co-insurance. What's the appeal of these plans are they are very low cost. Many of them are $0. In 2022 in Forsyth County, these plans are somewhere between $0 and $99. But most people elect in the $0 plan ones. These plans also cover drug coverage, which a supplement does not. That's another advantage of getting a Medicare Advantage plan. And last, to fill out Medicare coverage is you have prescription drug plans. They can cost anywhere from $7 to $120 when you get them as we call a standalone plan, if it's not part of your Medicare Advantage plan. The reason A, B, and D are bolded is because you have to get them. And required only meaning in if you don't elect in them when you're originally eligible, you try to get them at a later time, you will have to pay a penalty backwards from the time that you were eligible.
Oh my God.
How much it is depends on the benefit, whether it's B or D. But in general, you have to pay a penalty. So you don't have to get an Advantage plan and you don't have to get a supplement. You can only get A, B, and D and be fine, but you will have out-of-pocket medical costs. So even though they're not bolded, most people get one or the other. But again, A, B, and D, if you don't elect in them, try to get them after you're eligible, you will have to pay a penalty. And I forgot to say with medical insurance, the Part B premium, not only if your income's under a certain threshold, you won't necessarily have to pay your Part B premium. There's a program for that. But if your income is above a certain threshold, you actually have to pay a higher premium based off your tax bracket. So the government, again, Social Security and Medicare work very well together. They know when you're born and they know your income, and that's how all this works together. So your Part B premium, if you made over a certain tax threshold, you may pay an additional premium based off your income 2 years ago. So if you retired in 2020 and your income was $50,000 higher, your premium when you retire in 2022 may be a lot more than you expected. Just something to think about. I see there's something in chat. I didn't know. Is there anything I need to answer? Okay. When you say the threshold, April, can you confirm what you mean?
When you say pay, when you make above or below a certain threshold, I was asking, what is the threshold? Is there like I'm sure there's an income amount, but what is that?
I don't know that off the top of my head. I would have to look that up because it changes every year, just like tax brackets change. But let's say you know what, I'm not even going to estimate because someone might quote me there, but let's just say that if you make over, say, 100,000, then you're going to pay that 170 plus, maybe an extra $10 or $20 a month, right? So that's just an example. I don't know those thresholds off the top of my head for this year, okay? But you can find information like that on the Medicare and the Social Security website, and I can send that afterwards. All right, so donut hole or coverage gap. I only include this because it's in the news a lot. People talk about a lot when they're older adults. It is a complicated algorithm is all I'm going to say. It's basically a cost sharing roller coaster. If you know anything about insurance, there's a formulary, right? When you create a plan, certain medications are paid at certain tiers, right? And that creates how your medication, what it costs, right? Whether it's below $10, whether it's 10 to 50, what have you. So the donut hole really is when your drug coverage starts at the beginning of every year, you either have a deductible or you don't. Once you pass that deductible, then you enter the phase of coverage where your insurance and you cost share, right? They pay a certain percentage and you pay a copay. In the coverage gap, it means you and the plan have hit a certain threshold. I think I had that up actually just a second ago. Like I was looking it up, maybe 4,000, 4430. So this year it's 4430. Once y'all hit that threshold, then the plan stops paying and you pay the full cost of your medication, except for you get manufacturer discount. So you're really not paying the full cost. You get a discounted rate from the manufacturer, but your plan's not paying. Then when you hit another threshold, then the plan picks up again and pays a higher copay, but that manufacturer discount goes away. And that's called catastrophic coverage. So you can see why I don't go into much detail because it's super complicated. But older adults deal with this every year because if they have a lot of medical conditions, they take a very high cost specialty drug, they're going to get in that third phase, that catastrophic coverage every year. And to get into that catastrophic coverage, though, they have to pay a lot going into it. Okay. All right. Next. So resources for Medicare. Again, Social Security Administration is a good place to start, especially for applying for enrollment benefits, enrolling in your benefits. The Medicare website is better for understanding your benefits, and then when open enrollment is every year. So every year you get a chance to change your drug plan or your Medicare Advantage plan. You can look at all the plans on Medicare.gov. You can create a login and it'll pull your medications and your claims. And so someone can do that, or with the help of a counselor or family member. And then last is SHIP, and that's with a P. Seniors Health Insurance Information Program. That is where I'm trained to learn about Medicare benefits. Every state has a version of this program, but they are trained through the Department of Insurance to help people understand the Medicare benefits and help them either enroll initially or to change their enrollment and plans from year to year. So if you are about to turn 65 or you have a family member who is paying way too much for their medications, you need to be in touch with the SHIP counselor, and they can sit down one-on-one and go through your benefits and run your enrollment options for you. And it's a free program. Very helpful and useful program. I see something else in chat. I thought the donut hole was going to eventually disappear. Did that change? Renee, that's a great question. From what I understand, and yes, it's supposed to go away in the sense that there won't be the hole in the middle, but I do think the cost sharing, I think what it is they're going to smooth out the cost sharing across the whole. The way I understand it is there won't be this roller coaster, that there'll probably be a higher cost sharing on the beneficiaries part, but it'll stay the same over the course of time. I don't think it's gone away at this point because, you know, like I showed online, there's still a coverage gap threshold. But during my next SHIP training, I will ask what that, but when that is officially supposed to go away. But yes, that has been the talk for years, is they hope to eventually get rid of that coverage gap. And so that there is cost sharing more evenly across the time. So great question, Renee. Medicare is always changing. I tell people it's a moving target. So next is, we're going to talk about Medicaid. So this is an old card. I think it looks slightly different now, but it's a gray card. And Division of Medical Assistance really is the one who provides this card. And that's because Medicaid's really ran more at the state level. So if you think about Medicare and its benefits and its coverage rules, that's really set at a federal level. And Medicare benefits are pretty similar from state to state. Now the plans, those advantage plans and the supplements available, they may differ a little bit, drug plans, and that has to do with networks, right? You know, HMO, PPOs, who are the providers, who can you get to cover at what cost? But Medicare benefits, original Medicare benefits, those are set at the federal level. Medicaid benefits are a federal and state program, but the benefits are really ran more at the state level and set. So it's assistance with your medical costs for those with low income and a medical need. So age, blind, disabled is the program that I'm really speaking about today, but there are other Medicaid programs. There's different tiers and categories. There's disabled workers, there's qualified Medicare beneficiaries, which I will discuss briefly, family and children, pregnant women, and there are some other special need groups. The thing that's most important to understand is Medicaid is the payer of last resort. So some people get Medicaid in conjunction with some other insurance they may have, like Medicare. But Medicaid's only going to come in and pay last, right? It's going to pick up the second. So it's always going to be a payer of last resort. Who's eligible? Someone who's 65 or older or disabled by definition. So some may be categorically needy. Their resources are below the income threshold. So right now that's set at $1,064 a month, $1,372 as a couple. So that's pretty low. And those rates, I think, change around April every year. So that will probably change in the next few months, but that's the current threshold. Assets are less than 2,000, 3,000 a couple. And you see here at the bottom, assets include bank accounts, checking accounts, stocks, bonds, CDs, real estate other than the home, and countable resources. We call them countable resources. And I am not a Medicaid expert. So let me tell you, I do not work for Medicaid. I do not work for DSS. So DSS determines what are countable resources. There are certain things that we know, but like, so for example, if you live in the home, your home is not a countable resource if you're living in it. Your primary car isn't countable because if it's the car you're driving. So there are certain things that aren't countable, but mostly liquidable asset. Anything that can be liquidated are going to be countable assets. So Medicaid covers services that Medicare does not. So dental, medical supplies, in-home health. Also, you could also qualify for Medicaid if you're medically needy. So those are 65 and older, disabled who has significant medical expenses. So their income may be over Medicaid limit, assets around the same, but must meet a calculated deductible or 6 month certification period. So say, for example, you wouldn't normally meet Medicaid limits, but because you have a medical condition, you have a traumatic event, and your medical bills are so over your income, you could temporarily qualify for Medicaid. So these are things that are determined at the DSS level, but that just to let you know that there are times when you don't meet the income threshold, there are times when someone may be able to qualify for Medicaid otherwise. So there are additional Medicaid programs. I tell people Medicaid is more robust than Medicare is. Medicare is still a very traditional insurance, right? It works just like your and I's insurance, right? Where Medicaid has more robust services. They have personal care services, which is the technical name for in-home support. Someone can come to your house and provide in-home help. Special assistance can be provided in the home or in assisted living. That's like an income to help keep someone independent. There's CAP program. There's some limited long-term care assistance. So if you're in assisted living or skilled nursing facility, those income and asset limits slightly change, but Medicaid or another pocket of funding can come help support your living in those long-term care facilities. And I wrote here at the bottom, consulting with the Medicaid caseworker at DSS or with an elder law attorney will help direct the older adult as the best choice to make. And that is really relating to the long-term care needs. I can pause, Sarah, if you want to go ahead and ask your question.
Thank you. So just to clarify on these last couple slides, like for instance, do you mind going back one slide? Okay, so under these Medicaid programs, are you saying that those programs are only available if the previous slide is determined to be applicable to the applicant?
That's right.
Okay,
so if you make $1,500 a month, you are, and your assets are 5,000, unless you meet the deductible period, you're not going to be eligible to get PCS or special assistance or CAP. That's right.
That's a huge, I know we're not talking about that donut hole slide, but like that's a huge portion of people between that are not going to be eligible for any of these programs, right?
That's right. And I can cover this a little later, more depth, but where I work, we provide in-home supports, and senior services is kind of one of the programs we work with that does this. But there are community-based services that help people in the home for those, basically for those people who make too much to get Medicaid and can't pay for things privately. And it's a large portion of the older adult population. If you think about people who make between, let's say, the $1,000 and the $2,000 a month mark, we call that really a gap in services, because many of those people cannot afford to get help in the home or pay privately. but don't qualify for necessarily these Medicaid programs. So there are some community supports, but they're not nearly as robust as or well-funded as some of these other programs.
Okay.
So yes, you're right. That's a lot of people who would not qualify to get help with these programs. And there was another question about assets, but let me finish this next slide and then I think I can answer that one because I'm almost finished. The next slide is Medicaid managed care. I included this because it's a hot topic. It's something that is still rolling out. It officially started in July 1 of last year. It was supposed to have rolled out earlier, but it officially began in July of last year, and it's managed care. So if you think about those Medicare Advantage plans, like I talked about, where these managed care organizations contract with Medicare to cover their beneficiaries, to cover the basic benefits plus some added bonus. This is exactly like what Medicaid managed care is at the state level.
Web webinar. What's up?
Okay. So Medicaid has contracted with you see these health plans below to cover Medicaid beneficiaries across our state. There's a lot of different feelings about this. And I don't know enough about all the benefits and how the trickle down effects are going to play out. I do think the state is hoping this will better align with covering Medicaid beneficiaries. I think hopefully the state's probably thinking it will hopefully help save them money because these agencies will cover the benefits more efficiently. But I think also these managed care companies may be better at providing, a more robust care, understanding what the beneficiary needs. So there's a lot of hope that these will better align with what our Medicaid beneficiaries need. However, it is a learning curve, huge learning curve. And from what I understand, there's still some gaps. And at this time, not all Medicaid recipients are on a managed care plan. There are certain categories of Medicaid recipients that they have not rolled into a Medicaid health plan. And that might be far in the future until they can figure out or nail down how those benefits are going to play out when they're managed through a third-party agency. So again, I'm not an expert on that. I do have and I'll send, I think this is in the PDF, but you can watch this YouTube from DHHS that kind of helps explain the purpose and the rollout of Medicaid managed care. Your resource for Medicaid, I don't know why I missed the last 4 letters of that word, but the Department of Social Services is going to be your local expert on Medicaid. That's where you go to apply in any county to get your Medicaid benefits. So we'll open it up for questions and why you might think of yours. I will go back. I think Joyce had a question. Go back. I'm gonna stop sharing. For Medicaid, what's the time limit to have assets such as a home in the person's name? Does my question make sense? Yes, it's the popular estate planning question. I am not an estate planning lawyer, so I don't get paid enough to answer this question probably in its entirety, but in general, the rule's 5 years. I think with assisted living, it might be slightly different, but in general, the look back is 5 years. And they say look back because when you apply for Medicaid, they're going to look back up to 5 years to see if you've transferred any assets to help bring that asset limit down. Now, if you spend it on things that were legitimately yours, upgrading your home, or if you move into a nursing facility, buying yourself new clothes and TV, so that it's really looking at putting those assets in someone's name is what they're looking at. So as far as I understand, it's a 5-year look back as the standard.
Thank you.
Other questions? That's a lot of information to absorb.
It looks like Sarah has a question.
Thank you so much. I really learned so much already. So just to make sure I understand it right, if staying on Medicaid for the time being, if you do not qualify for Medicaid, then your only other choice for assistance in some of these areas, like if someone has, well, Parkinson's or older and Alzheimer's or something, then it's private pay or some kind of social service offering like senior services or something. Like that is the extent of the landscape. Do I understand it?
You got it. So the federal and state funds that PTRC and senior services offer have home delivered meals, in-home assistance, adult daycare, adult day health. There's transportation, congregate. There are these services and they are offered at no cost to the community. However, Renee, maybe you have these numbers. I can lean on you, and I know you had your hand up. I found this a couple of years ago. If you saw the amount of money that was poured into Medicaid at the county level versus the money that's put into what the funds we use is called Home and Community Care Block Grant. That's the official name for it. It's a tenth of what Medicaid spends. So if you think about how many people are served under our programs versus how many people need it, it's just not enough. So, but yes, that you summed it up pretty well. If you aren't eligible for Medicaid services, you either need to pay privately or try to receive a grant or based service. Let's see, Renee, go ahead. I'm going to read what they were saying in the comments.
I was just going to, you did such a great job, very, very comprehensive. I think the only thing I was going to just point out is that's why agencies like senior services are so important, because so many people, the vast majority of people, fall into the gap where they make too much to qualify for Medicaid, and they don't really make enough to privately pay for services. And you don't really fault companies that they're in business to make money, but there's so many people in the middle. And the only reason why so many people are able to stay at home, or what we call age in place, is because there are community-based services and supports that are available to support them in their efforts. So they may not need everything, but just getting one program or service can make a huge deal in their ability to continue living independently in the home. Most people want to age in their home and die in their home if they have a choice. And I just think we don't appreciate how many people can afford to move to Arbor Acres, but they make too much to receive other benefits. And that's not a dig at all against Arbor Acres. It's a beautiful place. It's just that it's just expensive.
Pardon myself, I was muted. Here are the expenditure reports from the division. So adult daycare, adult day health in Forsyth County, that is ran by senior services. You see the numbers here. CARES was a temporary grant, but you see the numbers here along this right side, right? So this is all, these are the community-based support, senior services, and some other agencies in Forsyth manage. They do have some other funding that helps support, but this is the majority of the money they get from federal and state grants, okay? 100,000, so family caregiver, health promotion, home delivered meals, very well-supported program, because we nutrition in older adults is very important. So about 3 million altogether for all those services. Here's Medicaid benefits. PCS, 4 million. CAP-DA, 3 million. The HMO plan, 4 million. Home health, hospice, Medicaid beneficiaries that receive help with the Medicare A and B premiums, 11 million. So 105 million versus 3 million. So, and this is something that's far beyond what I can even reach today, but generally this just shows you that that the supports for older adults and prevention of putting them into nursing facilities, the funding is just slightly backwards. And it's been that long. I think I missed that line actually. I want to say it's somewhere in here, and I apologize. I probably should have had it up, but there's a line for there's special assistance in home, adult daycare, skilled nursing facilities is somewhere in here, but I can't, of course, because I'm trying to find it right now. I can't.
We saw it, it was 42 million.
It's 42 million. There it is. All right, there it is. So you think about it, it costs the state 42 million to keep people in skilled facilities, and they're only spending 3 million on keeping them living at home independently. So, so this isn't to make you be like, oh my God, this is awful. You know, my parents don't have help. You know, there are supports. The best thing I can tell you, and this is what I love the most, is what I'm a huge advocate for, is if you know what you're dealing with, then you can better support the people that you love and care for. So people show up at our doors. Renee can say this. We say people call us frantically because they realize their loved one needs help and they don't know where to access. They don't know where to go help. And they're like, they're not eligible for anything. You know, the best way you can support them is just understanding and learning what is or is not out there. That just gets you in the right frame of mind to know where to navigate the system. And whenever you have questions, you can certainly call me. SHIP counselors, there's agencies like where Renee works, senior services all over our 12 county region that can answer some of these questions for you as you start to have to navigate.
I think Sarah has another question.
Go ahead.
I'm so sorry, everybody. I work with immigrants. So how many of the services that are available through social services generally require have questions about citizenship status? And also, should I assume that Medicaid is only open to those with Social Security numbers?
That is slightly out of my league. I know, and Renee might be able to answer this question because she deals with, well, I understand that our home and community-based block grant, right, doesn't require citizenship, home and community-based services. However, Medicaid is directly tied to your income, right? So if you think about it, you can't qualify for Medicaid unless they know your income or your, so you have to usually have SSI, which automatically qualifies for Medicaid, or Social Security income below a certain threshold. I think you have to be here for a certain period of time to apply for those benefits. And that is, I can't speak any more on that because I don't want to speak out of turn or say something wrong, but that's the only way I understand it is certain Medicaid benefits are really tied to that person's income level and disability. And so those things can't be accessed until a certain time period, from what I understand, of being here. There are things like emergency Medicaid, and that would be the only other thing I can think of. Yes, Renee, sorry.
No, I'm sorry. If people are refugees and they have legal refugee status, then they automatically will get Medicaid services for a certain amount of time. They have a time period where they have to become naturalized citizens, and then they'll lose their SSI and their Medicaid benefits. That's what I know. I've worked more with refugees than with immigrants.
So if you understand more about the difference between Medicare and Medicaid, raise your hand now. Yeah, it's a little more good. It is still very confusing. So Medicare is really, if you just think about it from the basic, Medicare is health insurance that you've paid into that you can access once you're 65 and older, or you become disabled before you're fully 65. Medicare. Medicaid is directly is to support the health, to provide insurance and benefits for those under certain income threshold who have that are blind, aged, or disabled.
Randy has a question.
Yeah, I'm approaching 65 closer than I'd like to be. So let's say I continue working and I work past 65. I've got good insurance through Goodwill, and I assume I would hopefully still be employed at Goodwill. So I guess that becomes, how do you determine, do I turn down the Goodwill insurance and take the Medicare, or how does that all shake out?
Case by case basis.
Okay.
It depends kind of thing. One thing is, it depends on the number of employers that your employer has. But then second is, it depends on what type of benefits they have versus Medicare, but there is an option. A lot of people delay their Medicare benefits and stay on their employer insurance. It's easier. Maybe the benefits are better, but for a lot of people, it's just easier. They stay on their employer benefits. Then when they retire, they apply for Medicare. And Medicare says that it is credible, as long as it's credible insurance, you receive no penalty. So if you work till you're 75 and decide not to get your Medicare benefits till 75, as long as you've been on that employer plan and it's credible insurance, that's fine. No penalty is due to you.
And you don't get any kind of kickback or anything that says, hey, I just saved the government a bunch of money over the years, right?
No, unfortunately, that doesn't happen either.
Dang it.
No.
There goes that scheme. There goes that scheme.
Look, and Randy and Crystal, we
Yeah.
know Randy probably makes about, well over 7 figures a year or whatever. Would his income keep him from, taking that option? No?
No.
Interesting.
No, Medicare doesn't really, the only time your income plays into Medicare, it really has to do with that premium for Part B.
Gotcha.
So basically
Karen-
tell them that you need to have them pay you a few dollars less those last 2 years or so.
Sure. Well, I
To
like
say,
the commercials.
drop it down from $1 million down to like $950.
Hey, Joe Namath is running these commercials for this, what is it called? Medicare Plus or whatever. Is that what you're talking about earlier? Joe
Yeah, those
Willie?
are the Advantage plans. And I really didn't
Yeah.
dig too deep because there's a lot of people on this call who probably aren't applying for the benefits, but because Medicaid covers stuff that Medicare doesn't, and that people have been frustrated for a long time. Medicare doesn't, in original Medicare, you don't get dental and vision benefits. A lot of those robust benefits I talk about, and there's a huge push for that. Advantage plans, to help increase their popularity, and because it helps save them costs on the back end, have started offering these benefits. Medicare doesn't necessarily pay them for it, but they include it in their benefit package. So some provide some preventative dental, some preventative vision, maybe some limited transportation to your doctor's offices. So some of these Advantage plans have started adding these bells and whistles benefits to help attract beneficiaries, but then they also know that sometimes paying for these things up front, these preventative measures, are going to keep these people at home and out of the hospital on the back end. Original Medicare, however, is slow to the uptake and has not quite included these benefits yet. So there's huge advocacy for that. Maybe in the next 5 to 10 years, hopefully see it. Maybe by the time you retire, Randy, you will see that, but yet to be seen. Joyce Bob, a good question. I've always heard that you need to make the most dollars possible in your last couple of years of work. There's an algorithm to Social Security. Again, this stuff's super complicated, but I have heard that, it's like an average, and then, but also like the last few years increased. That's when you need to go to like a tax consultant or to, it's a financial investor. But if you just want to get a good solid idea of your relative income, I would say sign up on SSA.gov and you'd be surprised what you can learn about your projections for how much you're going to make depending on when you decide to retire.
That's
Crystal,
great.
Aaron has his hand up. Oh, go ahead, Joyce.
I was just gonna say, that's great advice, but I have always heard this. I've heard it from physicians, I've heard it from nurses, I've heard it from all walks of life in healthcare, that they need to make the most they could make the last couple of years of their employment to have the most benefit. So I don't know, I'm gonna work until I die, so I don't know.
Yeah. It's complicated. Some people say, well, it makes sense to retire early at 62. Think of all those years you're not going to have that income, right? But then you also get that lower level of Social Security.
Mm-hmm.
If you wait till full retirement age, you're going to get a higher percentage, but you missed out on income for possibly 4.5 years. So, I mean, that is a mathematician would have to do that, and I can't do that. So it's a personal choice too. Aaron, are you around? Do you want to ask your question?
Yes, can you hear me, Crystal?
Yes.
Perfect. Thanks for the time this morning. I had a quick question that may be beyond the scope of our conversation, but I thought I'd ask anyway. When you think about state-run facilities or nursing homes compared to your Arbor Acres that could, where residents or patients are paying with Medicaid, when you think about sometimes the quality of care can be a little bit different. What resources exist for maybe even complaints or just things that could be improved? Do you know?
That is a great question and very timely question, considering the news over the last few weeks. If you heard it, I won't go into details, but first of all, here at the PTRC, we under the aging department, we have the ombudsman staff. These are dedicated folks who go into nursing facilities to look at complaints from either the residents or their families to help mediate any issues. They work with both sides to try to come up with a resolution. It may be as simple as I'm not getting my meals on time, or they're not hot, or my mother is, her laundry is not coming back to her room. Just things that you find inconsistent with maybe their care. It also helps to uphold the residents' rights. So the ombudsman for each county is a great place to start. There's one for each county here, and they go into assisted and skilled nursing facilities. Unfortunately, at this time, independent living facilities are not under an ombudsman's purview. There's also a hotline. There's also Medicare. There's also DSS, just depending on what level of facility it is and what type of complaint you have. So if you want to learn more about the different avenues of advocacy, depending on your situation, please reach out to me and I can get you in touch with the right folks. And as far as retirement communities versus other facilities, CCRCs, places like Arbor Acres, those folks pay a fee to live there, and they prepay, but parts of their facility may still be accessed from the community. They may still have Medicaid or Medicare residents in their nursing facility. So they're still being, they may still have to meet certain requirements that other facilities do, but you're right, because of their private pay funds or because of certain other avenues, certain other conditions, you may see a difference in staff to patient ratios because they may be able better to fund and keep. But I would say across the region, and anyone on this call that works with long-term care will tell you this, in-home care is at a critical point in our long-term care facilities and in home. We cannot staff enough CNAs to give adequate care. They have been paid at $9 and $10 an hour for decades, and hospital systems are taking them away from these other facilities. So when you see news stories where there's staffing shortages, like someone said to me yesterday, that could have been anyone. Right now, everyone is struggling. So if you know of someone needing a career path that loves older adults, we really desperately need them in the CNA world and long-term care.
Thanks so much, Crystal.
And Bob reached out to me. Bob, if you don't know Bob Kane, then you really need to know him, especially long-term care. That's the first thing everyone says when they come in long-term care. Have you met Bob Kane? Bob knows everyone, and he is a great networker. And one of the best things he does is create a directory. And you can contact him if you'd like to know a little more about his directory, but it is a great way of knowing assisted living, skilled nursing, adult daycare, geriatric physicians. Who is it that serves older adults in the Piedmont region? He could be a great access, but also senior services where Renee works has an information and assistance line called Helpline. I obviously feel very drawn to them because I worked there for 5 years. So they are a great resource if you just are at the point where you're like, I don't know where to start. My mom needs in-home help or assisted living and I can't figure out one. Call Helpline and they can really give you the resources to start making the decision, having the conversations. So any other questions? We have 1 minute left. I can give it back to you or I can stay on for as long as you have questions. It's up to you guys. I know April has to leave.
Crystal, I appreciate the shout out. I'll be quick. I just put my contact information. Anybody in this group emails me, you're welcome to get on the listserv. You get a monthly update and you have the welcome to use my cell phone to call and pick my brain if I can help, along with the good folks at Senior Services. Thank you.
All right. Well, I appreciate you all coming today and asking some really great questions. And I hope that you will all be ready to join us next Wednesday for Healthcare Program Day. I'm very excited about some of the activities and the folks we have lined up as speakers. It's going to be a heavy day. I'm telling you, we've got a lot of heavy stuff, but a lot of really fun activities pulled in. Ethany and our whole committee have worked hard with the support of April and the leadership staff. So I can't wait to see you guys again in the next week. I hope you enjoyed my bags with my little girl's drawing, if you picked one up. So good to see you guys. Have a great rest of the week.